I'll be explaining the internal features of brainstem, and I'll try my best to make it as easy as possible. Let's get started. So let's start first with talking about the nuclei and the fibers, or also called tracts. So the fibers, they could be ascending, which are sensory. They reach the brainstem, and we call them lemnisci. And we are going to discuss four types of lemnisci. Or they could be descending, which is motor, and they could be pyramidal or extrapyramidal. You can refer back to the tractology video. Then, for the nuclei, the cranial nerve nuclei from 3 until 12, these could be shared or parasympathetic or extrapyramidal or other nuclei. Let's start with the shared nuclei. Now, the shared nuclei divides into two, solitary nucleus and the nucleus ambiguous. The solitary nucleus is for the taste and it includes 7, 9, and 10, and we see them mainly in the pons and the medulla. For the nucleus ambiguous, it includes 9, 10, and 11, and it's mainly only in the medulla. For the parasympathetic one, we have 5, which is in the midbrain, we can see the Edinger-Westphal. In the pons, we see the lacrimatary, and also we can see the superior salivary. And in the medulla, we can see the inferior salivary, and we can also see the dorsal vagal nucleus. And they come always with a motor nerve. So we see the parasympathetic always with a motor nerve. The extrapyramidal one, these could be the superior and inferior colliculi, the red nucleus, substantia nigra in the midbrain, and the olivary nucleus in the medulla. Other nuclei are the gracile and the cuneate in the closed medulla, if you remember in the previous video. Now, whenever we mention the reticular formation, we also mentioned it in the external feature video. It's basically fibers that are all over the brainstem and the thalamus, and they connect cerebellum with the cerebrum and the basal nuclei. And we said they're very important for what? The vitals, like respiration, cardiac function, blood pressure, and we said what? It's divided into two, which is pontine, excitatory, and medullary, inhibitory. Again, the reticular formation has an excitatory part and an inhibitory part. Excitatory called the pontine, inhibitory called the medullary. And this is how it will look like. So, this is the pontine, and this is the medullary. The pontine, which is excitatory, and the medullary, which is inhibitory. Now, let's talk about the 6 important transverse levels. And we have here the first one, which is the superior level of the midbrain, and it's at the level of the superior colliculus, the inferior level of the midbrain at the level of the inferior colliculus. And then I have the caudal pons, or the pons inferiorly, which is at the level of the facial nucleus. And then I have the open medulla, and then for the closed medulla, I have two parts, which is the upper closed and the lower closed. The upper closed is mainly at the level of the sensory decussation, and the lower closed is at the level of the motor decussation. Now, how can I know how to differentiate between which one is medial or lateral? Medially, M, always with motor. So if I have a medial lesion, it will affect the motor functions. And then laterally, I have the sensory. So sensation, whenever I have a lateral lesion, it will affect the sensation. Okay, so again, this is repeating what I've just mentioned right now. Now let's dive more in depth with the lemnisci. I have four types of lemnisci: medial, spinal, trigeminal, and lateral. First of all, before we dive into it, what is a lemnisci? The ascending tracts or the ascending fibers, they have an extension. So let's say this is the fiber. What extend from it, the extension that start from the decussation, which goes again and ends at the thalamus, this extension we call it the lemnisci. So the medial lemnisci, it's basically what formed of the axon of the gracile and the cuneate. And since it's gracile and cuneate, we think of what? From the tractology lecture, proprioception and fine touch. And it will be where, because it decussate, where it decussate in the upper part of the closed medulla. So once it decussate, it will be the opposite side of the body. So Again, it starts in the gracile and the cuneate, and it will be at the upper part of the closed medulla, and there will be sensory decussation. And then I will take a look at the lesion. I will see if the lesion is above this decussation or below it. Now, if it's above the decussation, it will be what? So it decussated, خلاص. Then what will happen here? Contralateral loss of the proprioception and the fine touch. So it's as simple as this. Again, medial lemniscus formed of gracile and cuneate. Gracile and cuneate associated proprioception and fine touch. And then it will decussate where? Upper part of the closed medulla. After a decussate, if the lesion is above it, it will be what? Contralateral loss of this proprioception and fine touch. For the spinal lemnisci, it's basically coming from the lateral and ventral spinothalamic tract. Spinothalamic tract. And these tracts are associated with what? Again, from the previous video. Pain, temperature, touch, pressure. And it's on the opposite side. Why? Because here it decussate in the spinal cord itself, not in the medulla. So again, it starts in the medulla. It starts from the medulla, but here, so the lemnisci they start from the medulla, but here the tracks they cross in the spinal cord, not the brainstem. So it will be what? Opposite side, loss of pain, temperature, touch, and pressure. Now, the trigeminal lemnisci, on the other hand, it's associated with what? The face and the scalp. So what will be there in the face and the scalp? Pain, temperature, proprioception. And it will be on the opposite side because I can see what? A decussation. So it will enter the pons and then it will synapse at the trigeminal nuclei and then it will go up. So enter the pons, synapse at the trigeminal nuclei and then go. Now, if I have a lesion here, it will lead to what? Because it synapse and it crosses and go up, and then I will be having contralateral loss of this pain and temperature and proprioception in the face and the scalp. Okay, and we're talking about the sensory part of the trigeminal, by the way. Now, coming here to the last one, which is the lateral lemnisci. So the lateral lemnisci is always associated with hearing. Put this in your mind, memorize it. So its hearing comes from both ears, but mainly from the opposite side. Now, it begins where? It will begin in the pons, and then it will end where? At the level of the inferior colliculi or the medial geniculate body. But mainly it ends in the medial geniculate because it's the most one. So M for music, remember? So it's for hearing. And some of it could be in the inferior colliculi. So again, it starts in the pons, goes up, mainly ends in the medial geniculate here, and some of it stays in the inferior colliculus. Let's talk about the midbrain. So the midbrain is what? It has cerebral aqueduct, which connect the third and the fourth ventricle. Remember, we said it's in the middle of the face. Now, it's divided into what? It's divided into a tectum, this one, a tegmentum, and cerebral peduncle, this cerebral peduncle. So the tectum here, it's basically posterior to the aqueduct. So this is the aqueduct, it's posterior to it. And it has the four colliculi, the superior and the inferior. The tegmentum, on the other hand, it's the central region. So it's like here in the center. It has the tracts, it has nuclei, and the reticular formation. Okay, so it has the reticular formation here. In the cerebral peduncle, it's the most anterior one. It has the crus cerebri and the substantia nigra, this one, the substantia nigra. And here I have interpeduncular fossa. Here I have the red nucleus. Okay, let's take a look at the midbrain. We have the red nucleus. I have what the medial lemnisci and the spinothalamic tract. I have here the oculomotor, and in the back here I have the colliculi, and the cerebral aqueduct here is in the middle. And yeah, this is how it would look like, the midbrain. Now, let's cut it and dive into in depth. So let's talk about the superior colliculi or the upper midbrain and the inferior colliculi or the lower midbrain. So let's start with the superior one. So in the superior one, what is the most important stuff that I will see here? If I'm cutting it in the superior area, I will see the superior colliculus, obviously. Okay, so the superior colliculus. And then I will see the oculomotor nucleus. Where is the oculomotor nucleus? Right here, the oculomotor nucleus. And then also I will see the red nucleus, this one, the red nucleus, and I will see the Edinger-Westphal, the one that we talked about, the Edinger-Westphal nucleus, right here. It's nearby to the oculomotor nucleus. Okay, now the oculomotor nerve, how will it leave? It will leave from the front. Oh, sorry, my bad. So it will leave from the front, just like this, and in the interpeduncular fossa. So from the front, and this is the interpeduncular fossa. So from the front, okay? The Edinger-Westphal is what? Let's remind ourselves. It's the parasympathetic nucleus. And as I said, it's next to the oculomotor. And what is it used for, the Edinger-Westphal? Is for your pupillary constriction and accommodation to light, your lens accommodation to light. So the pupillary constriction and lens accommodation to light. And I have here the medial lemnisci. Now, from lateral to medial, so from lateral to medial, the arrangement of it, if we get asked in the exam, it's lateral, trigeminal, spinal, medial, LTSM, LTSM. Memorize it like this: lateral to medial, LTSM. Okay, now again, this is it, as you can see. So the lateral, trigeminal, spinal, and medial lemnisci. And this is how the superior colliculus midbrain would look like: cerebellar aqueduct, lemnisci, and the red nucleus, and the substantia nigra. Okay, and the most important features again in it are these: superior colliculus, red nucleus, Edinger-Westphal, oculomotor. Now, how would we differentiate it from the inferior colliculi, or the lower midbrain? So what are we going to see here is the inferior colliculus and the trochlear nerve. Trochlear nerve goes from behind, dorsal. The red nucleus, where is it? There isn't any red nucleus. And the trochlear nerve, it leaves posteriorly, but it crosses the midline like this before exiting. I will see here the substantia nigra. So again, excuse me, the substantia nigra is seen in the inferior one, okay? So substantia nigra, which is basically extrapyramidal tract. It would appear dark in color because of the melanin in it, and it helps in your muscle tone. Now, if this was removed, what will happen here? Parkinson disease. And then I also see the crus cerebri in this case. Crus cerebri, we mentioned it multiple times. What will it have? The corticospinal tract and the corticobulbar tract. And if there's any issue in it here, it will lead to contralateral hemiplegia, which is paralysis of the opposite side of your body. So it will be paralysis of one side of the body, which would be opposite, contralateral in this case. Okay, let's talk about the midbrain clinical syndrome. I have the Weber syndrome, called the alternating oculomotor hemiplegia. The issue here is what? I have this ventral midbrain will be affected, which is the oculomotor nerve will be affected because we said it goes outside like this anteriorly. So oculomotor is affected, the ventral midbrain is affected, and the crus cerebri, the peduncle, is affected. And it's caused because of what? It's occlusion of the posterior cerebral artery. I told you it's very important to know this artery, okay, in the previous video. Now, what will happen in this case? They will have, because it's affecting the oculomotor, so ophthalmoplegia on the same side, because it's affecting the same side. So ipsilateral ophthalmoplegia, which is ptosis, drooping of the eyelid, dilated pupil, and down and out eye. So the eye is looking down and out. And loss of accommodation. So it's affecting the eye mainly because of the oculomotor nerve. And because of the rest, because we said corticobulbar and corticospinal are in the crus cerebri, so we'll have contralateral hemiplegia. Okay. The Benedict syndrome, on the other hand, it affects what? It affects the oculomotor nerve, and it affects the medial lemnisci, remember the LTSM, and also the red nucleus itself, but the crus cerebri, it's not affected. And again, it's because of the PCA. It's occluded in the tegmental area, the area in the center right here. Now, because of this, again, oculomotor, so ophthalmoplegia, same stuff that I told you about. But here, because of the medial lemnisci for sensation, I will have hemi anesthesia, loss of what? Sensation, of proprioception, and it will be contralateral here. So ipsilateral eye, ophthalmoplegia, contralateral sensation here, ipsilateral eye, contralateral motor. Okay, let's carry on here. Again, because of the, okay, so this is because of the oculomotor and because of medial limnae. What about the red nucleus? The red nucleus, because of it, I will have what? Ataxia. Ataxia. Involuntary ataxia or movement. Okay, now let's talk about the pons. The pons is between what and what? It's between the medulla and the midbrain. And it's a relay station between the cerebrum and the spinal cord. And it has, again, from the previous lecture, we know 5, 6, 7, 8. Okay, now grossly, what can I see? I can see it's divided into an anterior and a posterior part. The anterior part, I call it the basilar, and the posterior part, I call it the tegmentum. Okay, now in the basilar part, what are the most important things that I see? I can see what? The pontine. I can see the pontine nuclei. Um, Let's just try to find it. So I can see the pontine nuclei just right here, the pontine nuclei, and I can see the transverse pontine fibers. So these pontine fibers, okay. Um, the transverse pontine fibers, we talked about them. They go to the cerebellum via the uh, posterior cerebellar peduncle, okay? Sorry, via the middle cerebellar peduncle. If you remember from the previous external feature of video, we have what the pontine transverse fibers. We said they go to the back, to the cerebellum via the MCP. Okay, and also I can see corticospinal and corticobulbar fibers, but they will appear exactly here. So again, on the anterior part, the basilar part, I will see the most important thing is the pontine nuclei and the fibers that go to the cerebellum posteriorly via the MCP and the corticospinal and corticobulbar. Whereas on the tegmentum or the posterior part, what will I see? I will see the floor of the fourth ventricle. I will see the floor of the fourth ventricle, which has the cranial nerves from 5 to 8. Okay, and also I will see the medial lemnisci, which will be right here. I will see the trapezoid body, this one, the trapezoid body, and I will see the reticular formation, which will be right here, the reticular formation. So this is the most important stuff that I can see in the tegmentum. Again, the fourth ventricle and then cranial nerve 5 to 8, the medial lemnisci, and the trapezoid body and the reticular formation. What other stuff can we see in this picture here? We can see also, again, trigeminal and motor root. Okay, you can ignore that. Just know that 5 to 8. Yeah. So this is the mid-level of the pons. Okay. Now, the trigeminal nerve nuclei. It's very important to know that the sensory nerve, it has 4 nuclei. So the trigeminal nerve nuclei, it has 4 nuclei, 1 that's motor and 3 that are sensory. So again, the trigeminal nerve nuclei, it has what? 4 nuclei in total. One of them is motor and the remaining are sensory. The motor one, it will be in the mid-level of the pons. So the motor one, it will be here, exactly. The motor nucleus in the mid-level of the pons. And then, so here, in the mid-level of the pons. And then the sensory, it will be divided into 3. The mesencephalic one, which will be the most upper one, okay? It will be in the midbrain. And then I will have the main sensory one, which is for touch and the pressure, okay? And then the spinal trigeminal one, which will be in the medulla below for pain and temperature. Then in the caudal pons, if I look at the end or the inferior level of the pons, caudal pons is also called the facial colliculus pons. Okay, why do we call it facial colliculus? Because basically I have the facial nerve wrapping around the abducens nucleus, forming for me the facial colliculus. So the caudal pons, what will I see at the level of facial colliculus? I see the fourth ventricle again. I see the facial colliculus, this one, the colliculus, this elevation, the abducens nerve nucleus, the facial nerve, and then the nucleus of the facial. and then the abducens nerve. So this is the facial nerve, this is the abducens nerve, and then this is the abducent nuclei, this is the facial nuclei. And then I can see here the basilar artery groove, and we can see here the middle cerebellar peduncle and the spinal tract and the nucleus of the trigeminal nerve. I apologize for the lagging of my iPad. Now for the clinical syndrome, I have the medial pontine syndrome, or also called the foveal syndrome. The lesion here is basically in the inferior and medial pons, so this area, in the inferior and the medial pons. And it's because of what? A stroke that affect the paramedian basilar artery, the paramedian one. Now what will happen in this case? What is it affecting? It affects here the corticospinal tract. I have corticospinal tract, so it will be contralateral hemiplegia. Again, it also affects the facial nerve, because remember I said I have facial abducens nerve, so affect the facial nerve. Once it affects the facial nerve, it will lead to ipsilateral because it's on the same side. So ipsilateral weakness in your face, so facial nucleus. And because of the medial lemnisci, also this is the medial lemnisci, so because of it, it will be contralateral proprioception and vibration. And because of the abducens nuclei, this abducens nuclei right here, I will have horizontal gaze. And because of the pontine nuclei, the pontine nuclei, I will have ataxia. Okay, ipsilateral ataxia. So it all makes sense once you know the structures that are here. Then the other Pons syndrome is the locked-in syndrome, and it's where it's basically bilateral in the corticospinal and corticobulbar. Bilateral corticospinal, corticobulbar, as because of proximal basilar artery lesion, which lead to bilateral ventral pons issue. Okay, what will happen in this case because it affect corticospinal, corticobulbar? It will affect the awakeness and consciousness. No, it won't affect awakeness and consciousness. Why? Because the reticular system will be spared, but it's affecting here the motor ones, so it will lead, because both of them are affected, and bilaterally there will be quadriplegic, not hemiplegia, quadriplegia, which is in the entire body, and they will have absent speech and facial expressions. So what will happen here? What's the key word in the question? Them communicating with their eyes. Now let's talk about the medulla oblongata. So the medulla, what does it have? It has what gray matter associated in helping the heart rate and the respiration. Also, it has 9, 10, 11, and 12 cranial nerves, and this is what we talked about in the previous video. Now, it's important to know that in the medulla oblongata, I will have inferior olivary nucleus. So I will have an inferior olivary nucleus, this mustache right here. Okay, what's important about this inferior olivary nucleus? It's the largest nucleus in the olivary complex, or in the extrapyramid. Okay, extrapyramidal tract. Where can we see it? Very important to know the location. It's in the open medulla. Okay, and it's associated with coordination and muscular movement. So if I have an issue here in this mustache, it will lead to ataxia. What about the other type of a nucleus, which is the solitary nucleus? Now, the solitary nucleus, it has a cranial part and a caudal part. So it has this cranial part and this caudal part. So the cranial part has 7, 9, 10, and I have a caudal part. So the cranial part, it will have what? Ipsilateral for the taste. Okay. It has cranial nerve 7, 9, and 10, as we said. So, ipsilateral loss of taste. So, it will have an ipsilateral loss of taste. Whereas the caudal part, it will be for the reflex control of your viscera and blood pressure. Okay, we don't have any cranial nerves. Do we see any cranial nerves? No, there is no cranial nerves. So, if it's associated with your viscera, so it's very important to know that the viscera is involuntary. The viscera is important for us to live. Now, if I have a bilateral lesion here in the caudal part, it will lead to death because it's affecting the viscera. okay, because the viscera helps in our respiration and cardiac functions. Okay, so again, this repeated the cranial part 7, 9, and 10 associated with taste. So it will be ipsilateral loss of taste if I have an issue here. The caudal part, it doesn't have any cranial nerves, so it's associated with your viscera, which is important to live. Any lesion here, which is bilateral, lead to death. Okay, yes, okay. Now let's talk about the nucleus ambiguous. What is about the nucleus ambiguous? It's shared motor nucleus. It's branchial for the branchial and the visceral arch. What do I mean by shared? It has 9, 10, and 11. So it's associated with the pharynx, the larynx, and the soft palate. So what will happen in this case? If there is a lesion to the nucleus ambiguous, it will lead to dysphagia, difficulty in swallowing, hoarseness of your voice, changing of the voice, and food regurgitation. So it's very important to know what each nucleus is associated with. This one with ataxia, the cranial part is for taste, the caudal part for death, nucleus ambiguous is for dysphagia, hoarseness, and food regurgitation. I have three levels of the medulla. So I have the level of the open medulla, and then I have the closed one, which has the upper part and the lower part. And we said upper part for sensory decussation and lower part for motor decussation. Let's start with the open medulla. So in the open medulla, it will open where? It will open to the fourth ventricle. So it will open posteriorly to the fourth ventricle, as you can see here. This is the fourth ventricle. I don't see any central canal in this area. I will have also the hypoglossal nerve. So this nerve, just like that, this is the hypoglossal nerve, which exit anterior and lateral. Between what? Between the pyramid and the olive. So between the pyramid and the olive. Between it, this is the olive and this is the pyramid. Between it, I have the hypoglossal nerve. And then I have the vagus nerve. So the vagus nerve, it will exit posterolaterally. Posterolaterally. This is for the open medulla, so it's simple. Now, for the closed medulla, the upper part, the sensory decussation, it has a central canal, okay? So the central canal will be right here in the middle. And they have the gracile and the cuneate. They will basically do what? They will come medially. So the gracile and the cuneate, they will come medially, okay? And they will form the tracts. It's called the internal arcuate tracts. Once it forms these tracts, the gracile and cuneate, it will cross with each other like this. Okay? They will cross in the midline. In front of what? This is the central canal, so they will cross in front of the central canal. And then, once they cross, we call this sensory decussation. This is why this is called the upper part of the closed medulla. And we call this sensory decussation the medial lemnisci, the one that we have always been talking about. Now, we cannot see any pyramids clear here because they have not crossed yet. So it's most important to talk about the sensory decussation, okay? So let's take a look at it here. I have what? I have the gracile and the cuneate. They come together, cross in front of the central canal. They will give me internal arcuate fibers, sensory decussation, and then it will be called the medial lemnisci. And this is how it will look like. I don't see clear pyramids yet. Now, in the lower part of the closed medulla or the motor decussation, again, I have the central canal, but the pyramid fibers, they will form what? The lateral corticospinal tracts. So I'll have lateral corticospinal tracts crossing like this, crossing where? In the pyramids, forming motor decussation. So oh my bad, wait. The pyramids, they will be identified in the upper closed medulla because I have sensory decussation which is away from the pyramid. It's only just in front of the central canal. But in the lower part of the closed medulla, I will have decussation of the corticospinal tract in the pyramid itself. Therefore, the pyramid won't appear as clear. So it will appear like this. So here we can see the pyramid like this and this. But here it appears more like flattened like this. Okay, I hope it makes sense and I'm sorry for the mistake. Okay, So again, here we have the pyramid tracks. They're crossing where? In the pyramid itself. Therefore, the pyramid is not appearing for us, and we call it motor decussation. Okay. Now let's talk about the medullary clinical syndromes. I have the lateral medullary syndrome called the Wallenberg syndrome. And here I have an issue in the pica, which is what? Posterior inferior cerebellar artery. Now, it will lead to what? Because it's happening in the lateral medulla. It would lead to ipsilateral dysphagia and hoarseness of the voice. The gag reflex will be gone because it affects the nucleus ambiguous. So whenever the nucleus ambiguous is affected, gag reflex will be gone, loss. And it affects the trigeminal nucleus, therefore ipsilateral loss of pain and temperature of the face. Okay. And contralateral loss of pain and temperature because it affects the spinothalamic tract, vertigo and ataxia because of the vestibular nuclei. Okay, and vertigo means false spinning sensation, and ipsilateral Horner syndrome because of the descending sympathetics. Now, for the medial medullary syndromes called the Dejerine syndrome, it's because of the paramedian branch of the vertebral and anterior spinal artery. In this case here, I will have what? It will affect what? The arms and the legs. So contralateral paralysis of the arms and the legs, and ipsilateral paralysis of the tongue, and contralateral loss of the tactile sensation because of the medial lemnisci. Let's revise it again. The lateral, it will affect what? The pica, and it will be here in this area, right? It will be in this area. So since it's in this area, it will affect the nucleus ambiguous, okay? And let me see if there's a clear picture to show it. Yes. So here's the nucleus ambiguous, okay? And uh, we have here the trigeminal nucleus, okay? And the solitary nucleus. So again, this is the nucleus ambiguous, and this is the trigeminal, yes, and this is the solitary nucleus, and this is the dorsal vagal nucleus. So know their places, and when we talk about each and every one, you get to know what becomes affected. Okay, so I will have the ipsilateral dysphagia and hoarseness, loss of gag reflex because of the ambiguous, and the loss of pain and temperature of the face because of trigeminal, and yeah, so it's here. The issue is here, not here. My bad. So the issue is here. Okay, and yeah, where are we here? Contralateral loss of pain and temperature because of the spinothalamic will be affected too. Let me see if it's appearing here. The spinothalamic. Yeah, spinal tract and trigeminal will be here. Nucleus ambiguous will be here. Vagal will be here. And the hypoglossal will be here. And the solitary also will be here. Yeah. And the vertigo because of the vestibular, and ipsilateral Horner syndrome because of the descending sympathetic. Here, on the other hand, the problem will be in this area. So since it's in this area, it will affect the pyramid tract. Okay. So contralateral paralysis of the arms and legs, and also it will affect the hypoglossal nerve, if you remember the hypoglossal nerve, so ipsilateral atrophy of the tongue, and the medial meniscus, it will affect contralateral loss of proprioception and tactile sensation. Now this is a summary. You can pause the video and read it. It will help a lot, honestly, in memorizing the syndromes and differentiating between them. Now, this is a slide to test yourself. So you can just pause the video, try to test yourself. And right now, I will